Okay. You want to start with EKGs? Or
Let's do antiplatelet, anti-thrombotic first, just to get that out of the way. All right, so today we're going to talk about antiplatelet and anti-thrombotic therapy, and as I said, in the future I may just split this lecture into 2 or 3 because there's just so many angles on this. But I put them together because, you know, when you have a patient who needs anti-thrombotic and antiplatelet therapy, the risk is very high, can be as high as 22 or more % of a bleed in 1 year, and the benefit, of course, is very high. And so, you know, challenging, tricky stuff. So we'll start with anti-thrombotic therapy. So if you have a patient who has atrial fibrillation, what you really should be trying to do is calculate their risk of stroke, which has nothing to do with how much of the time they're in AFib. For the most part, so if they had a lone AFib, so to speak, which doesn't really exist, or if they have it very infrequently versus all the time, consistently, chronically in AFib, their stroke risk is the same. And their stroke risk depends on risk factors. CHADS, VASC is the score system that we use now. Heart failure, high blood, heart failure, high blood pressure, age greater than 65 is a point, greater than 75 is 2 points, diabetes, previous stroke or TIA, blockages in there. So coronary artery disease or peripheral artery disease is the VASC, and female gender. And we used to use CHADS score. The reason why we went to CHADS VASC is to really delineate between that, you know, just people who are at CHADS 0, are they really 0, or do they have, you know, 1 or 2 risk factors for stroke? And if you're a CHADS VASC 2 or more, then in general, you start anti-thrombotic therapy. And of course, you counterbalance that against their risk of bleeding. Many of these things, many of the risk factors for bleeding are the same as the risk factors for stroke, unfortunately. And the has bled score, also listed for reference on the slide, should be calculated to decide, you know, the risk benefit of anti-thrombotic therapy. So once you decide on anti-thrombotic therapy, I didn't include in this slide, and I maybe should have, edoxaban. And so dabigatran is Pradaxa. If your creatinine clearance is more than 30, then you go to 150. We don't really use 110. For AFib, it was a studied dose, and there are some situations where you might use it. If you have some renal insufficiency with a creatinine clearance less than 30, you go to the 75 twice-a-day dose. And I'm going to talk about metabolism and side effects and things of that nature in the coming slides. For rivaroxaban or Xarelto, if your creatinine clearance is over 50, you go to the 20 milligram dose, and under 50, you go to the 15 milligram dose. And so under 50, 15 milligram dose. So then you have Eliquis, apixaban. So with Eliquis, you have an ABC: age, body weight, creatinine. So if your age is over 80, you're a thin person, creatinine is your body mass is under 60 kilograms, or if you have renal insufficiency with a creatinine above 1.5, so no creatinine clearance here, just a number. And that's the way they did the trial. If you have 2 out of 3 of those risk factors for bleeding, old, thin, renal insufficiency, then you go to 2.5 milligrams twice a day. So you see that Xarelto is our once-a-day option. Eliquis is our, is another good option. Pradaxa is an excellent option. There's the first one that I started using first to market. So Pradaxa is a factor 2 inhibitor. Xarelto with an X, or rivaroxaban, is a factor 10A inhibitor, as is Eliquis. Edoxaban can be used. Their market strategy was that it would cost less. I had a lady the other day who couldn't afford Xarelto or Pradaxa or Eliquis, and I prescribed her edoxaban. It was going to cost her $1,000 a month. The dose is 60 milligrams if you use it, if you have normal renal function, 30 milligrams if your creatinine clearance is low, similar to Xarelto. So there you go. Anyways, so now you can use these in addition to atrial fibrillation to treat deep venous thrombosis. Pradaxa, the dosing is the same. For Xarelto, you're going to use 15 milligrams twice a day for the first 21 days and then treat generally 3 to 6 months. I usually treat 6 months after an acute DVT or PE. Eliquis is 10 milligrams twice a day for 7 days. Then again, you go to their creatinine clearance, etc., for the remainder of the 3 to 6 months for the treatment of an acute deep venous thrombosis or pulmonary embolism. So there you go with that. A lot of these new or direct, I guess now direct, we call them direct oral anticoagulants, DOACs, are exchanged and absorbed through the gut via the PGP receptor. And so that's true for all of them. But I will point out that in the case of Xarelto, again, rivaroxaban Xarelto, the bioavailability is much more with food. And so that's probably the biggest one where you have to have them take it with a meal. That's always, I think that's somewhat true with all of these because they are absorbed across the gut wall via the PGP receptor. So anyways, for reference, and as far as hepatic versus renal metabolism and things of that nature, you'll notice that in the case of Eliquis or Xarelto, they still have quite a bit of hepatic metabolism. And so even with people who have renal insufficiency, you can use those medicines. So I don't generally use them on dialysis patients. I had one dialysis patient who was on 2.5 twice a day of Eliquis with, of course, the highest hepatic metabolism. And he had bleeding into his bladder for 2 weeks while the medicine got out of him and they dialyzed him and things like that. I do have people who safely and effectively have been on that medicine, Eliquis 2.5 BID on dialysis, but I'm always very nervous about it. So, you know, we all take our risks. I put this in for reference. You know, there are about 100 times less medication interactions for the direct oral anticoagulants as compared to warfarin, but there are some interactions. And I point to, for example, if you have people on Multac for a rhythm control strategy, that's dronedarone, which is similar to amiodarone, and it came in and out of vogue with some findings that it may be dangerous in heart failure, etc. But if you have people on that medicine and you have them on Pradaxa at the same time, you have to be careful. And then again, there's some other antifungals that have some interactions and things of that nature. So just things to bear in mind. I put the trial data for the randomized control trials for Pradaxa, Eliquis, and Xarelto up here. This is the RELY trial. Every trial had a little different sort of things, that's just way that they looked at things so that they could have their own angle on market share, of course. Every one of the medicines were about the same or generally better than warfarin, with a few caveats. In the case of Pradaxa, going back to the randomized control trial data, warfarin had a little less GI bleeding, but Pradaxa had better stroke prevention, statistically significant. Sorry, just to back up for a second, this is a box and whisker plot. Most people are familiar with it, but what you look at is the trial finding in the box and the 95% confidence interval in the whiskers. So if you cross the line of unity, that means that there's no statistical significance in that finding. And if you are on the side of the line of unity, that means that there is a statistically significant finding that you're sure with 95% confidence that that was a true effect based on the randomized control trial. So there's RELY. Here's ROCKET, Xarelto. That it basically was the same in many respects. Seemed to be a little bit better for intracranial hemorrhage. And the funny thing about all this trial data is we were for a long time comparing trial to trial, which is bad science anyways. And then we have all this aftermarket research, which if you look at one study versus the other, it goes every which way from stroke prevention to bleeding. And everybody's got their angle, but they're basically the same if you look at the main data, the preponderance of data. Oh, one more thing on Xarelto. Xarelto really is a twice-a-day drug, but everyone else was a twice-a-day drug of all of the direct oral anticoagulants. So they said, well, we'll just give it once a day and see if it still works, and it did. And so even though we know that the pharmacokinetics make it a twice-a-day drug, we still use it once a day in atrial fibrillation. Now, there is some new interesting trial data, which I won't present today, but I'll just reference quickly. That's Atlas 2 in COMPASS. Atlas 2 was after acute coronary syndrome. They gave people low-dose Xarelto and had less death. We don't use it for that in the US. It didn't get FDA approval. COMPASS looked at people who had so-called polyvascular disease. They have coronary disease as well as carotid and peripheral arterial disease, and those people had lower risk of stroke and limb loss and a bunch of stuff with low-dose twice-daily Xarelto, 2.5 milligrams. So in any case, it is sometimes used based on its pharmacokinetics being a twice-a-day drug and other indications, but not in atrial fibrillation. Use it once a day as previously discussed in the dosing. So here's Eliquis, similar kind of thing. The trial data showed lower bleeding compared to warfarin by quite a bit and improved stroke, also statistically significant. Aftermarket data comparing Eliquis to Xarelto and things like that. It'll go one way or the other depending on which registry the trial is from the trials that I've reviewed. I did want to review this. There was a question for a time that you could have a rebound effect, a procoagulant effect after stopping Eliquis. And the original packet insert said you may need to bridge them with Lovenox and things like that. That's since been debunked. That doesn't really happen. It was a spurious finding in the trial data going back to originally Aristotle. So don't worry about that procoagulant effect. It's not real. Been disproven in the meantime. All right, so that's antithrombotic therapy. There's a ton of stuff with it, but as far as the direct oral anticoagulants, indications for use, sizing people up for their risk of stroke versus bleeding and how their absorption is, there's at least some things there for reference that hopefully are helpful. So then we'll move on to antithrombotic therapy. And of course, in cardiology, we mostly get very concerned about antithrombotic therapy in the setting of acute coronary syndrome, after which we may often put a stent in somebody's coronary artery. And one of the main reasons, to be honest with you, for me to originally develop this talk was to really project the importance of adherence to dual antiplatelet therapy, not only after stenting, but after any acute coronary syndrome. So I'll present that data, but we'll go on from there. So in the setting of acute coronary syndrome and atherogenic plaque ruptures and a thrombus forms on top of that, causing near or total occlusion of the vessel and myocardial, muscle cell death of cardiac myocytes. So that's the process. This is what an activated platelet looks like on an electron micrograph up close and personal. I'll talk a lot about this process of platelet activation and discussing antithrombotic therapy, of course. So what I tell patients, and I mostly talk about this with smokers actually, is that a normal platelet that everyone has in their blood system is a nice, smooth, walled cell that runs through our bloodstream, which becomes activated by the presence of collagen. So if you have a cut in a blood vessel, you expose the underlying protein of that vessel wall, which is collagen. That collagen causes platelet activation. It causes those nice smooth platelets to become spiny and sticky to the vessel wall. And then those activated, and then, for going to the physician level, those activated platelets release dense granules, which contain various things that further lead to more platelet activation, such as adenosine diphosphate, ADP, thromboxane A2, thrombin. They become linked via the GP2B3A receptors that become expressed on the platelet cell surface, von Willebrand factor, et cetera, that ADP comes back to those inactivated platelets to activate them as well, as does thromboxane A2 in addition to thrombin and collagen. So platelet activation begets more platelet activation, and you end up with this platelet fibrin mesh that causes that causes a blood clot, and in the case of acute coronary syndrome, causes vessel occlusion. You narrow the lumen, can't get blood flow, no oxygen delivery to cardiac myocytes, and they die. Again, going back to the physician level, focusing in on this interaction between ADP and the receptor on the platelet surface, which is the P2Y12 receptor. This is a very important interaction that occurs in the process of thrombosis, as in the case of acute coronary syndrome, but also could be in the case of stent thrombosis. And this interaction between ADP and the P2Y12 receptor is central to all of these prothrombotic stimuli, leading to propagation of the thrombus with additional procoagulant activity, platelet aggregation, you're building that thrombus, the fibrin, all those things, more granule secretion, and again, it's just all about this propagation of the thrombus. So what we have as one of our most potent means of treatment for non-ST elevation acute coronary syndrome is our P2Y12 receptors. And so we used to use ticlopidine, ton of problems, side effects, and things like that. These days, our primary P2Y12 antagonists are ADP antagonists. The antagonism of that receptor ADP mechanism are Plavix, clopidogrel, Prasugrel or Efient, and Ticagrelor or Brilinta. And so you'll see your patients or use these drugs in the setting of non-ST elevation acute coronary syndrome on these medicines. They're all, relatively good medicines. Some are very good medicines, and some are pretty darn good medicines. You'll notice in this graphic published in the New England Journal of Medicine that all are absorbed through the gut, but Plavix and Prasugrel or Efient are prodrugs that need to be converted by this cytochrome P450 system in order to become their active formulation. Ticagrelor, on the other hand, requires no conversion by the liver. So a lot of my partners prefer Prasugrel. I personally prefer Ticagrelor. They both are better than Plavix, and Plavix is way better than nothing, which I'll show you in just a moment. I will talk in a future lecture, maybe next month, about non-ST elevation acute coronary syndrome, but I'll only point out here that in the case of P2Y12 receptors, in the setting of non-ST elevation acute coronary syndrome, which is also true in ST elevation acute coronary syndrome, that the use of P2Y12 receptors upstream or in the aftermath of the event is level of evidence, as class of recommendation 1, level of evidence B. It's about as high as it gets. So very useful therapy. That reviews class 1, level of evidence B. for non-ST elevation acute coronary syndrome. That recommendation goes back to a trial called the Cure trial. Cure trial took people with unstable angina and non-ST elevation acute coronary syndrome and randomized them to Plavix or placebo in sort of the modern era, and they found that Plavix had lower risk of cumulative hazard of death from cardiovascular causes, myocardial infarction, or stroke for 12 months after non-ST elevation acute coronary syndrome. So that sort of made it the standard of care, and then of course made Plavix the standard of care for a non-STEMI. And then Prasugrel and Ticagrelor came on top of that and showed additional event prevention. So if somebody goes in and they have non-STEMI and they get typically stented these days, relatively less commonly they'll be medically managed, and a subset of them may also have bypass surgery. In all of those cases, you want to put them on dual antiplatelet therapy, aspirin and a P2Y12 antagonist for 1 year, regardless of any of that stuff, because in the Cure trial, some were stented, some had a STEMI, some had bypass surgery. The whole trial benefited from dual antiplatelet therapy for a year. So the guideline is to put them on that stuff for a year after non-ST elevation acute coronary syndrome. But what if you don't? And so you have to go back to some of the early trial data to figure out how important it is to put people on dual antiplatelet therapy, for example, after a stent. And if you look here, there's about 6 times in between these trials, aspirin alone versus aspirin and another P2Y12 antagonist. There's about a 600% increased risk of events, coronary events. And this is in the case of bare metal stents. Drug-eluting stents is even worse. And so I'll show a little bit of trial here that there's about a 16 times increased risk of stent thrombosis if you stop dual antiplatelet therapy premature to 1 year of therapy. And that trumps any other risk factor for stent thrombosis by a huge amount. So if you look at the hazard ratio, there's about 16 times higher risk of stent thrombosis if you stop their usually P2Y12 receptor, compared to, if they had a chronic total occlusion that got revascularized, maybe it's twice as likely that they'll have stent thrombosis if they've had a previous MI or bypass or things like that. There's some risk, but no risk is as big as stopping their Plavix, Prasugrel, or Prasugrel or Ticagrelor after an event. So there you go. Important to do. Now, when you're sizing patients up for the risk that they could occlude that stent, you should know that there are some stent characteristics that do increase the risk of stent thrombosis when you're sort of putting in your mind like, well, they absolutely have to have surgery, which is usually the reason why it gets stopped. What's the chance that they'll clot that stent off? Well, the acronym is BELT. So if they have a bifurcation lesion, so you got to look at the cath report for this. If they have a bifurcation lesion, so they stented a bifurcation lesion, that's a risk. If the stenosis is eccentric, that's a risk for stent thrombosis. If they have a long area of stents, sometimes we used to call them a full metal jacket. You just stent the whole artery, stem to stern. That's a risk for stent thrombosis. And if the artery is tortuous, that's a risk for stent thrombosis. And so here's some sort of pictures and some high-resolution CT of various stents, which are difficult to deploy in the case of a bifurcation stent, as you can see there, and may not completely oppose the vessel wall, and therefore become occluded with thrombus and a bunch of badness. Sometimes you can have a technically bad result where you don't get that stent all the way to the edge of, to the edge of the artery wall. there, and you get, that's a risk for stent thrombosis. There is some thought that you put the stent in and the artery positively remodels, and that could be a risk. And so there's all these sort of kind of semi-technical details why a stent could occlude, but that furthermore reinforces the idea of the need for dual antiplatelet therapy for a year. And so at 1 year, what you're going to see here, if you see this histological stain of neointima, this is vessel growth on the inside of the stent struts, neointima. In a year, the vessel is going to heal around that stent, as many of us may know, and therefore the risk of stent thrombosis is much less, and you can take them off their dual antiplatelet therapy. There is data out to 30 months for dual antiplatelet therapy for event prevention in special groups of people, typically diabetics, ongoing smoking, and other risk factors for stent thrombosis. But in general, 1 year of dual antiplatelet therapy should do it. And this is a case in the literature of somebody who had a big anterior ST elevation MI when they stopped their dual antiplatelet therapy. So you see this anterior ST elevation, reciprocal inferior ST depression on this EKG. I won't read it in full because we'll go through some general stuff about EKGs, and we've talked about STEMIs and showed some cool pictures. We'll come back to that in future EKG talks. But so a couple of things to kind of wrap up on these medicines, as far as contraindications to them. Prasugrel, if they've had a previous stroke, you shouldn't use it, black box warning. Ticagrelor, despite the fact that I do generally prefer the medicine based on the mechanism and the outcomes data, often people will tell you, I just feel winded, and you're wondering, could this be, maybe their coronary disease progressed, or they had stent thrombosis, or something squirrely is going on. It's often the ticagrelor. It's usually after a couple of weeks they get over this sensation of dyspnea, and it does have to do with the mechanism of the drug. You can also have bradyarrhythmia. Some people even heart block with ticagrelor. So there are some caveats to look out for, but in general, still much less cardiovascular death after the use of that medicine. So, okay, so that's antiplatelet therapy. So we got antithrombotic therapy, your factor system, the direct anticoagulants or factor 2 or 10A inhibitors, and then you have antiplatelet therapy, and then you put those together and you really lose your ability to form a blood clot with a bleed. And so I'm going to talk a little bit about the WOEST trial. So what do we do when we need to be on Coumadin or a direct oral anticoagulant and dual antiplatelet therapy because you got a stent? So you had AFib, you got a heart attack, you came in, got a stent. So we know that the risk of bleeding is about 20% with warfarin or a direct oral anticoagulant, and I'll sort of refine that, and dual antiplatelet therapy if you stay on it for a year. So benefits high, risk is high. So they randomized people to basically get Plavix and Coumadin. This was before the direct oral anticoagulants were quite popular. Or triple therapy, aspirin, Plavix, and Coumadin. And the endpoint of the trial was any bleeding, the WOEST trial published in the Lancet. So 573 people were randomized, few people were excluded, usual trial kind of layout there. And as you can see, if you have people on triple therapy on the red line versus dual antiplatelet therapy on the blue line, they have an enormously high risk of any bleeding. It's not just major bleeding. There's a variety of ways to look at bleeding. There's a TIMI risk score system, a BARC score system. There's 1 through 5 on the BARC and all this stuff. So there's a lot of posturing on bleeding. And what really matters, did you just have to hold a little groin pressure, or did they have a massive GI bleed? They're different, obviously. But in the case of any bleeding, there's tremendously high amount of any bleeding at 1 year with triple therapy with Coumadin. In the WOEST trial, 44%. So, there's got some issues there. If you look at that a little bit more closely in the Coumadin and Plavix arm, that's the double therapy arm, all-cause death was actually lower, and that was statistically significant compared to triple therapy, so people died less because we know bleeding causes some death. And so that, of course, is very important. Cardiac death in the double therapy was even still lower than the triple therapy, and people may have strokes or other things. And then, of course, stent thrombosis was the same. No statistical difference between stent thrombosis with double versus triple therapy. So the WOEST trial kind of started this ball of, really we shouldn't have them on 3 drugs for a year. You just shouldn't do it because they're going to die more and they're not going to clot off their stent as much. So then we had this question about, does that data for Coumadin really apply to the direct oral anticoagulants? And the next trial that came along, and that I'll kind of sort of wrap it up with this for this part of the lecture, was the Pioneer AFib trial. And so they took 2,000 patients, they randomized them 1 to 1 to 1. It was published in the New England Journal. They had this really weird group 1 through 3 thing. There was a little, if you read the article, it's kind of hard to wade through, but the group 1, they got 15 milligrams of Xarelto, or 10, depending on the renal function, 10 or 15. If they had renal insufficiency with a creatinine clearance of around 30, they got 10. But most people 15, plus the P2Y12 inhibitor of the choice of the interventional cardiologist after PCI. And most of them chose Plavix. Very little Ticagrelor or Brilinta because they thought they'd bleed more for 12 months. So those 2, double therapy for 12 months, group 1. And low dose Xarelto, which they use in Europe, and I referenced Atlas and Compass where they use these doses of Xarelto, plus dual antiplatelet therapy for 1, 6, or 12 months. And that was group 2. And it was sort of up to the discretion of the treating clinician, whether they would go 1, 6, or 12. And then group 3 was Coumadin plus dual antiplatelet therapy for 1, 6, or 12 months. So those are the 3 groups. Okay, so randomization scheme for reference. Here you go. So I put again on the side, this group 3 was Coumadin, and they had way more cumulative event, which was bleeding. Way more bleeding in the Coumadin group versus either of the 2 options for Xarelto. Now granted, the Xarelto was at 15 milligrams and not aspirin in group 1, and 2.5 milligrams with the dual antiplatelet therapy in group 2. It wasn't powered to detect stent thrombosis, but they didn't really have much more of it in there. And the risk of death was about the same for the 3 groups, but definitely more bleeding on the Coumadin arm. And so I'll just say that when it comes to that, what I'll generally do, I generally favor Xarelto over Coumadin in people with AFib. We're still getting some Eliquis data in as well. Remember that Pradaxa had a little more GI bleeding in the trial data, so I generally don't use that in these patients. And what I'll do is I'll put them on triple therapy for 3 months, actually. I put them on 3 months, that's what I do. And then I cut them back to double therapy. And I will use 10 or 15 of Xarelto often, and that 10 milligrams is a little bit off label, but it was based on the trial data. And so I use 10 of Xarelto and usually Plavix to finish out their year in general for these people. And the reason is because with Coumadin, their INRs fluctuate a bit more, and they do have an increased risk of bleeding, which can be very high. In the Pioneer trial, they were only at 25%, but in the WOEST trial with Coumadin and triple therapy, they had 44% of risk of bleeding. So there you go, a lot of content. Sorry, I know that was super busy. And I will break the lecture up in the future, but good amount of information.
Yeah, any questions for Dr. Anderson or Sharmisa at this time?
All right, rock and roll. Let's go to EKGs. I'd be happy to take any questions offline too. And so it was just a bigger topic. So there you go. All right, EKGs. This is fun and easy, I think and hope, of course. But I'll just review a little bit and then just go over intervals today, really, and show a couple fun and cool EKGs, I think. So again, remember rate, rhythm, axis, intervals, hypertrophy, ischemia. The heart rate, we're generally talking about the R to R interval, and you can count boxes to figure out what the heart rate is. There you go, 1 bit box, 300 beats a minute, 2, 150, 300, 4, 75 beats a minute. And if there's 5 big boxes in between QRS complexes, then you are at 60 beats a minute. If it's over 5, you're just under 60, just slightly bradycardic, as in this case. And there you go, boxes counting. And then alternatively, especially in an irregular rhythm, you can count QRS complexes, and the strip is 10 seconds, so multiply by 6. Again, this is the same EKG that I zoomed in on from previous, which is just about 60 beats a minute in sinus rhythm.
We do have a question here. Would you
Oh
mind
yeah,
addressing that?
sorry. Yeah, no, please. So post-stent on Effiant, 1 month, insurance wouldn't play. Yeah, so thank you for the question on the Prasugrel. The most important time for stent thrombosis is the first 1 to 3 months. So we may try and push it to 3 months, but if you've got them on a month of aspirin and Prasugrel, then yeah, change them to Plavix and have a clear conscience. They're probably almost certainly gonna be fine. The absolute risk of stent thrombosis is quite low. So yeah, change them to Plavix for sure. So
Thanks for the question.
yeah, of course. All right, so back to sinus rhythm, which we previously talked about, P for every QRS, QRS for every P, upright Ps in the inferior leads you should see in sinus rhythm. And usually you should see a biphasic P in V1, but not always, not always. So again, just to review, QRS axis is normal if it's between -30 and 90. So that's a normal axis right there. And we also had previously reviewed with QRS axis, if standard lead 1, the R is greater than the S, and that's also true for standard lead 2, that's what I mean by upright, then that's normal axis. And then if it's down in 1, upright in 1, down in 2, it's left axis deviation, and the rest is there for reference, which we'll go through again, paying specific, doing specific examples of what could cause QRS axis to deviate, etc. But for today, it's going to be intervals. Today is about intervals. So we talked about intervals a little bit in the past, and remember there's a QRS interval, there's a QT interval, there's an RR interval and a PP interval. The PP interval usually should be the same as the RR interval. I don't know why I labeled that RR interval, but I'll have to fix that. So when you talk about intervals, the question is what the significance is and who really cares. A PR interval should be between 120 or 200 milliseconds. 200 milliseconds is 1 big box. 120 is 3 little boxes. If it's short, then you should look for a delta wave that could be Wolff-Parkinson-White syndrome. But a lot of times I'll see a PR interval of 100 milliseconds and a tachycardic heart rate, and that just reflects the effect of adrenaline on the AV node. And so it's not really of significance, honestly. But look for a delta wave if the PR interval is short. If it's long, then think about heart block, first, second, or third degree. And even though I'll go into bradyarrhythmias specifically in its own set in a different EKG lecture when we have a little bit more time, but QRS interval should be, QRS interval. So here's the PR interval. The QRS interval should be less than 100 milliseconds. If it's 100 to 120, you've got an intraventricular conduction delay. If it's over 120, you have a bundle branch block, either left or right, depending on the morphology, which I'll also specifically discuss in the future. And then there's the QT interval, which should be referenced to the RR interval. So a QTC, which is what you really care about, if the heart rate is normal between 60 and 100, is the QT divided by the square root of RR, and you can do MedCalc and all these other things. Truly, it should be less than 440, so I'll change that too. Less than 440 milliseconds. If you look at the QT interval and the risk of sudden cardiac death, a very low QT interval actually has a slightly higher risk of sudden cardiac death, and a long QT interval, as we all know, has a higher risk of sudden cardiac death. So, so there you go, QTC. And then the RR interval defines heart rate, as we've previously discussed. So there you go, that's intervals. Okay, a couple fun EKGs. This is a lady who I saw, a very nice little old lady, came in from an outlying community to our medical center when I was on call over the weekend. And she was having a big GI bleed. They put her on octreotide, and when she came in with her GI bleed, this was her baseline EKG. Sinus rhythm, nearly tachycardic. You're about, so 300, 100, 300, 150, 100. So just under, there's about just over 3 big boxes in between R waves. So your rate is about 90 perhaps, beats per minute. Rhythm is sinus, P for every QRS, QRS for every P. P's are upright in the inferior leads. So sinus rhythm, rate about 90. Axis is pretty much normal, maybe a little bit of right axis deviation because of the deep S, which is associated with a right bundle branch block. So deep S laterally is a right bundle branch block. So you can see all those deep S's. And then there's some sort of non-specific T-wave flattening inferiorly, etc. Not a lot really to talk about on this baseline EKG, but what is the PR interval? And so, got a couple minutes. If anyone wants to take a shot at it, I'll leave it out in the open for, about 30 seconds. What do you think this represents, and why am I talking about the PR interval in the context of the discussion that we already had? So the answer to the PR interval is it's variable. It's a variable PR interval. So if you march out these P waves, if you really focus in, they're marching right through, and many, many of them are non-conducting. So the atrial rate here actually became a little bit tachycardic. Atrial rate, tachycardic. The ventricular rate is bradycardic because she has heart block, complete heart block. So this is complete heart block. And if you look at the morphology of the QRS, if you recall that deep S wave in the lateral leads with the right bundle branch block, now it's a left bundle branch block. And that's because she has a ventricular escape rhythm. So this is complete heart block with a ventricular escape rhythm. And if you get that widening of the QRS, different bundle branch block morphology, you have to think about this. This lady got taken off of octreotide and she went right back into regular rhythm. So at least when I left her on Saturday morning, there was no indication for a pacemaker. But this is pretty uncommon that we see this with octreotide. There's various things that cause heart block, electrolyte abnormalities, thyroid dysfunction, usually calcific conduction system disease, and then they get a pacemaker. But octreotide is way down the list, but kind of a fun case nonetheless. So, all right, so now another one. This is a great one that Sharmisa brought to me. I was super excited about this EKG naturally. Again, what's the PR interval? And so I'll spoil it for you again. It's variable, but for a totally different reason. And what I'll point out to you is that there's a phenomenon called grouped beating. So if you are looking at a bradyarrhythmia and you have a regular marching QRS, regular marching, that's very useful as compared to grouped beating. And if you see grouped beating, you should think about Wenckebach, Wenckebach heart block. So that's Mobitz 1, type 2 Mobitz 1 heart block. And so if you look, let's just do this. Okay, here you go. So here's the atrial. So there's a P wave here that I didn't flag, but the atrial rate's about 68. P wave, P, 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 P. And if you look at this PR, it's long for sure. So there's baseline, first degree AV block, but we're going past that to type 2. Second degree type 1. Second degree type 1. So the PR gets longer, drops, and then it's short again. So when you look at Wenckebach, you should always, because if it's type 2, second degree type 2, the PR interval will not change. But in second degree type 1 Wenckebach, the PR interval does prolong and then drop. So you want to look at the last conducted PR interval and before the drop, and then the first conducted PR interval after the drop. And then you measure that with calipers there and there, and you compare them to each other. And if it's long and then short, then it's Wenckebach. So this is Carl Friedrich Wenckebach, circa mid-18th century. Looks like a very stern cardiologist there, kind of a character. That's the namesake of this rhythm. And so then the ventricular rate, of course, is slower because you have all these non-conducted P waves. So you want to tell us about this guy, Sharmisa? Give us a little vignette.
He was 76-year-old male, underwent his 5th back surgery. His back still hurt. He was basically asymptomatic. No dizziness, lightheadedness, shortness of breath, chest discomfort. His main concern was his back, and we looked at him with a slow rate in the Wenckebach and figured he probably needed a pacemaker. He didn't really want to undergo the pacemaker because he felt fine.
Yeah, naturally.
Yes.
Yeah. The back stops hurting when the heart stops. So I don't think that's probably the most effective form of anesthesia, though. So anyways, I left a little YouTube video that you guys can, it's very silly, and it has to do with Wenckebach. So peruse at your leisure. Thank you for your time. As always, it's a pleasure. And if you have any other comments, I will go over specifically bradyarrhythmias in the future. Because I had a longer first part of the segment, I wanted to just focus in on intervals today and define a little bit of their importance. We were going to talk about the idea of, so you have an EKG with first degree AV block. What's the significance of it? Sharmisa and I were talking about that beforehand, and I want to say, and I think this is important, that even if you have if you have a so-called trifascicular block, you have a right bundle branch block, left anterior fascicular block, and first degree AV block. So it's the highest sort of resting conduction system abnormality that you can have before complete heart block. That really still only progresses about 2% of the time, 2% per year to complete heart block. So you watch these patients carefully, but they may never need a pacemaker. You just have to be in tune with their symptoms. So I think it's important to note those things. And, if they do have a trifascicular block, that don't put them on 100 of toprol for their blood pressure alone in the absence of other indications. But outside of that, it's, sometimes an academic point.
Tom, did you have a question?
Yeah, I did, and I'd like to go back to the anticoagulation story.
Yeah.
Just a fantastic presentation. I'm Tom Berg, Medical Science Liaison with Eli Lilly.
Yeah.
Could we talk a little bit about the anticoagulation need in primary prevention? High-risk patients, comorbid conditions, that might be beyond the scope of your talk today, but I think it's a whole nother population where anticoagulation might be important. And aspirin and so forth. What do you think?
Yeah, I think that's a great point. There's so many angles on the anticoagulation. idea. So I would emphasize, I think to start just at first, there's so much undiagnosed AFib. But once you make the diagnosis, hopefully most of those people haven't had a stroke yet. And so you're still in the primary prevention of stroke with anticoagulants for AFib. In the case of Atlas II, which I did not go into, they put people on 2.5 milligrams of Xarelto and had less strokes, presumably because if you infarct your apex, you have a big nidus for a left ventricular thrombus, which can then cause a stroke. So in a way, that's primary stroke prevention, but secondary prevention in the sense of the heart attack. In the case of COMPASS, these were people with polyvascular disease, carotids, peripherals, coronary, and they had less strokes and things. So that also is almost along the lines of primary prevention in many cases. Outside of those, hard diagnosed pathologies, I think we need more data to figure out about these oral anticoagulants. So excellent point, and more to come for sure.
All right, just 9 o'clock now. We'll finish up for the day. Thanks so much for joining us, everyone. We will be back next month, April 12th. Dr. Anderson, any ideas on what you'll be talking
Probably non-ST elevation ACS. I think it's just the right topic on the heels of this anti-thrombotic therapy.
Great. All right. Thanks. We'll hope to see you there, everyone. Have a great day.
Good morning.